All right, hey everybody, back in the locker room again. We're going to take on a different topic. It may feel a little bit like deja vu again. Last time we took on a musculoskeletal topic of neck and back pain, and before that we'd been talking about neurodegenerative disorders, and we're going to kind of go back into that realm, talking about concussion and the progression from concussion to something called CTE, or chronic traumatic encephalopathy, a neurodegenerative disorder with its onset from trauma. And just to reflect back, if you want to establish a baseline for this, you can go back to the other neurodegenerative talks, and even going back as far as into the mental health talks, because there's a thread or a continuum that goes along with these. But anyway, for today we're going to talk about essentially brain injury. Concussion being a mild form is where we're going to focus, and we're not going to talk a lot about big time brain injury, but how can minor brain injury precipitate into a sort of a disaster or a neurodegenerative disorder of CTE. And as we've done throughout this series, we're always talking about threat versus safety and the threat-stress response and what that does to our bodies, to our physiology, but also to our brains. It's all the same soup. And again, we're going to try to tie this in with this concept of threat and safety, and we do this sort of underneath the umbrella of the polyvagal theory, and also under the umbrella of cytokine theory, and see how concussion and CTE shape up through that lens. So let's go to the board here. So just a quick summary of what we covered. We're looking at this through the polyvagal and cytokine theory. We've talked previously about the threat cytokines, the pro-inflammatory nociceptive catabolic cytokines. We'll be talking about those again today, and not so much about the safety cytokines that are anti-inflammatory, decrease pain, and cause anabolism or build tissue. So kind of the opposite side of the equation. We're going to deal more with the stuff in the red. So if we're talking about threat, let's go to our threat chart here. Here it is. And recognize that we have this long stack of potential threats in our body, and our body tends to react to threats very similarly, regardless of it's a repressed emotion or an attack by a virus. There's some real commonalities. And so the argument here today is that traumatic brain injury is a physical threat, and we should anticipate our body is going to react to that physical threat very similarly to how it reacts to all these other threats. So that's kind of the platform. We can come back to this a little bit later towards the end, but let's turn back this way and talk about concussions. So concussions are minor brain injuries, but they're associated with neurologic dysfunction and symptoms. And we don't see, if we do a scan, if we do a CT scan or an MRI, we're not going to see macroscopic injury to the brain. And the question is there some microscopic injury that goes on in the brain in concussion? And arguably, yes, in some concussions, there probably is some significant true microscopic injury, but there may be other things that are happening that don't really require a true structural injury to the cells or the axons in the brain that may be at play. So that's what we're going to talk about. But the symptoms of a concussion, if we look at what they tend to be, you're going to see impairment in attention, impairment in concentration, tend to see an increase in anxiety, see an increase in vigilance. You can see an increase in impulsivity. You can see an increase in mobilization, kind of that mobilization response that we see under threat, a fight, flight, mobilization type response, hyperkinesis. They frequently have emotional lability. They have a difficulty with regulating their emotions. Part of the frontal lobes that helps control that gets a little bit disconnected. You may see some social instability as well. And a lot of this stuff here tends to line up with the frontal cortex, the neocortex that we talk so much about, maybe particularly in the ventral medial prefrontal cortex. And then you may see some impairment in memory and impairment in language, and that is the medial temporal lobe of the brain typically. That's also part of the neocortex that we've talked a lot about in past sessions. And then you may see difficulty with reasoning, rational thought, planning and strategizing, difficulty with insight, impairment in judgment, and those are all frontal lobe functions as well. So we have the dorsal lateral prefrontal cortex that's in charge of a lot of those types of activities. So with concussion, and let's just add down here, maybe a little bit separate from the neocortical functions of the brain, we see a tendency to have issues with a little bit of vision and coordination of vision and our balance system, a sense of imbalance or vertigo type sensations. And that may be more down here where there's been some change in the brainstem. So what I'm going to point out here is that if you have a concussion, if you're shaking up the brain in the box in the skull, is that the pattern of symptoms that comes out of that doesn't seem to be like a focal sort of brain injury. I mean, it's not like, you know, you typically see the occipital lobes, which seem like they are at risk for being bumped and bruised in the box, in the skull, having particular problems or presenting with symptoms from that part of the brain. The parts of the brain that seem to be presenting with symptoms tend to be a little brain stemmy, but very much in kind of this neocortical part of the brain that we're always talking about in these sessions. So you have to sit back and think, okay, what's going on here if this isn't just, you know, a random kind of sporadic brain contusion? So we're going to dig into that and how that may then evolve into something like CTE. So when you get a concussion, that is something that's probably a fairly complex physiologic change in the brain. But you could potentially have something like a contusion of the brain. So that's like, you know, somebody punches you in the shoulder and, you know, you get sore and it hurts there for a while, a little bit of inflammation going on there, maybe a little bit of tissue injury going on there. You know, it heals in a relatively short period of time. So certainly it is possible that with these concussions that there's an element of a contusion that we just can't see macroscopically on imaging, but it's at a lower level than that. So I think that is something we have to include in the diagnosis. But the other things we see in concussion are we see gray matter dysfunction. So the gray matter is the cells of the brain. The cell bodies tend to look gray, and they tend to be more on the surface of the brain. And interestingly, after a concussion, not after a major brain injury, but simply after a concussion, we actually see some thinning of the gray matter, some decrease in the volume of the gray matter. And there is a pattern to this, and that thinning of the gray matter tends to occur in the frontal lobes and the medial temporal lobes. The same stuff we talk about over and over again, kind of what I keep calling the neocortex. There's actually thinning of the gray matter with concussion. We also see white matter dysfunction. So the white matter is all the wiring in the brain. All of this stuff, all the cross connections and the wiring that goes down through the brainstem, down the spinal cord. And it is wrapped in myelin, again, referring back to a previous neurodegenerative talk. And the myelin helps speed the rate of conduction in the brain. And the myelin shows up as white. So we're also seeing some white matter dysfunction, but we're also seeing a loss of volume in the white matter, and it tends to be more in kind of the tracks that we've described where the gray matter loss is as well. Okay, so that's really interesting. Now, I do want to mention that although we're going to talk a lot about the physiology of concussion, there's this other microscopic event that can occur. As we said, we can contuse the surface of the brain and maybe beat up a few cells. Maybe one or two might die. That's a possibility. But there's this other phenomenon where we have all of these axons running up and down, and these are wires. So they're in the brain and they're in this substance of the brain. And when we get a high velocity kind of injury or concussion to the brain, those axons are at risk for getting stretched or even broken. That's been referred to as diffuse axonal injury. It's probably not really diffuse, and I've put up here in this red area here, this is the corpus callosum of the brain. This seems to be a particular area that has a high incidence of axonal injury and may be part of this microscopic concussion dysfunction. So the corpus callosum essentially connects the two hemispheres of the brain. And so you can imagine if you get kind of a wild brain injury, maybe rocking back and forth and rotational, that these two lobes of the brain might be slightly doing different things in the impact. And that sort of wobble to the brain, disconnected wobble, can put some shear forces across that connection and can stretch those axons or stretch those wires and can actually break them. So that's not a good thing, right? And then the other place where this happens is down here, primarily in the brainstem, primarily in the midbrain, very high in the brainstem. And the analogy that I always use for that is that, if the big bulb of the brain is kind of like a mushroom, and that's the part that gets sort of shaken up in the box, and you might bump these poles of the brain with that, then the brainstem comes up like the stalk of a mushroom. And if you get a high impact head injury with a rotational component to it, it could be very similar to taking and spinning the top of the mushroom on the stalk. And if you do that exactly where it's going to tear, it tears really high up on the stalk. It doesn't tend to tear further down. And I think that's the same physiologic phenomenon we see here in the midbrain, that with that little rotational component to many brain injuries, you get some twisting of those axons, some stretching, and then perhaps even rupture of those axons that can cause a lot of the brainstemmy symptoms that we have, including balance impairment and some visual impairment and vestibular impairment and even lower levels of arousal, because we know from past talks this part of the brain is very high in dopamine concentrations, and if those tracks get disrupted, it can impair kind of our level of arousal and even our mood. So let's we've kind of talked about a little bit of mix of physiology and structure here, and what I really want to get to that I think is super interesting in concussion is the glial tissue of the brain. So the glial tissue, sort of used to be thought it was like the support network of the brain, like we used to think of the fascia as the support network, the connective tissue of of the body, and we know the fascia has many more functions than that. Well, so does the glial tissue of the brain. So with impact, or actually probably with any threat, glial tissue tends to get activated in a certain way. So what's in the glial tissue? Well, let's actually go down here now and change from the gross anatomy down to the tiny anatomy with just looking at a neuron here real quick. So here's the cell body of the neuron, and it's got a nucleus and a Golgi organ and a mitochondria and endoplasmic reticulum, and it's got these little dendrites sprouting out this way to help with connections. And then it's got this long axon going down here with these axon terminals, where all the neurotransmitters collect and get pushed out to the next neuron, right? And then all of this orangey stuff surrounding the axon is the myelin that insulates it, so it conducts a lot faster. So that's the neural tissue. This little body here would be the gray matter that we're talking about, and this axon with the white myelin would be the white matter that we're talking about. So we've covered that, but what's the glial tissue? Well, we have these microglial cells here that are really fascinating. They get activated, and they can do a number of different things in the brain, but under threat, stress, trauma type stuff, they behave a lot like monocytes and macrophages in our blood. They go around and kind of start to clean up the mess a little bit. But the other thing they do is they secrete cytokines. Now, they can secrete anti-inflammatory cytokines, but in this case, under this trauma, this threat, this traumatic brain injury, this concussion, they're going to throw out some pro-inflammatory cytokines. And then the other cell that's very interesting here are the astrocytes. So these guys, they all migrate around, but these guys are very mobile, right? The astrocytes tend to want to congregate a little bit more around the axon terminals and have more influence over neurotransmission and amplification of transmission or dampening of transmission. But these little astrocytes also, when they're under the threat stress response, are going to throw out some pro-inflammatory cytokines. And then here's an oligodendrocyte attached kind of here to these little myelin areas. So, and these guys have some significant metabolic activities in the brain, but they primarily are there to produce myelin, the insulation that's full of lipids that surrounds the axons to improve the conduction of the axon. So that's kind of just a basic sort of microanatomy look at what's going on. So with glial activation, we're going to see an increase in interleukin-1 beta. We're going to see an increase in interleukin-6. We're going to see an increase in tumor necrosing factor alpha. Those are our typical pro-inflammatory cytokines, and there are other ones, but those are the ones that we really like to deal with a lot. Interesting, interleukin-1 beta may have a lot more to do with myelin production, whereas interleukin-6 probably is very pro-inflammatory and catabolic, and tumor necrosing factor alpha has some other kind of unique properties in its influence over the microglial cells. But anyway, we'll move on. And then there's another cytokine that comes out of the chemokine category, CCL2, which is going to be important because that is something that induces cellular migration. So it's going to pull the migrating microglia in the direction of trauma, but it also may influence peripheral cells like monocytes, macrophages, and lymphocytes to come into the brain and help with the task of resolving the injury. And then anytime you get these pro-inflammatory cytokines up, you're going to get an elevated in prostaglandins, kind of our more traditional, what we think of the inflammatory pathway that ibuprofen works well on. And then you're going to also see an increase in nitric oxide, which has some implications in metabolism and tissue injury that can play a part in increasing oxidative stress on the brain. So you're going to see this glial activation and the release of these cytokines and other chemicals. And what does that do? Well, the cytokines change the blood-brain barrier. Okay, so I've kind of demonstrated that here. Both the astrocyte throwing out some cytokines, these microglial cells throwing out some cytokines. And what it does is it makes the endothelium of the vascular bed, or the blood-brain barrier, which kind of protects our brain from our external environment, right, most of the time. But when the cytokines come out, the blood-brain barrier opens up. It gets more porous. Well, that's really helpful because it allows for the fatter white cells like the monocytes, macrophages, and lymphocyte type stuff to get out of the blood vessel and come help with resolving this traumatic event. And it also allows for fatty acids, which are usually too fat to cross the blood-brain barrier to get out, and that has a significant role in metabolism. But it can also lead to some increased fluid or water getting across, so you can have an increased water density or swelling or edema in the brain when the blood-brain barrier loosens up. And unfortunately, other things can get across, like proteins you might not want to get across, antigens that could perpetuate this response, or even toxins that potentially could sneak across and actually increase some of the inflammation in the brain with this phenomenon. So we really don't want that blood-brain barrier staying open too long. We want it to open up and let the stuff in that we need to resolve the injury, and then kind of tighten back down. Okay, so we covered the change in the blood-brain barrier and what that does. And then the other thing that we always have to talk about with these pro-inflammatory cytokines is their catabolic effect. So they change metabolism, and they do this in particular patterns. The change in metabolism that we tend to see in certain parts of the brain looks kind of catabolic, or it's really taking apart tissue instead of building tissue. And we've talked about that in past lectures, but I'll come back to that in just a second. So again, the idea is we want to get in here, clean up the injury, and then switch back to our more normal physiology and rebuild tissue. When that doesn't occur, we see prolonged post-concussion type symptoms. So these symptoms, and when they go on too long and the cytokine levels are too high, we can also see people move more into that immobilization type physiology of freeze and faint, where they stop looking so anxious and hypervigilant, they start losing energy, they become more immobile, they become more submissive, and kind of feel like they're surrendering to the world. They look depressed. So this sort of acute, if it goes on too long, can move into that kind of physiology as well. But even more worrisome, when it really goes on too long, that's when I think we see the CTE phenomenon. So, with CTE, if you look at the literature, and you'll see this in ALS or Alzheimer's and things, they look very similar, kind of when you take a snapshot of the brain. And so the stuff that keeps getting talked about in these neurodegenerative conditions tends to be this kind of stuff, perhaps more of a discussion around ADP43 and more discussion around tau and synuclein, perhaps than amyloid or even ApoE4 in things like ALS and CTE that seem to have a history of brain injury being something that puts you at risk for that. But we also know Parkinson's, if you have a history of brain injury, you're also at risk. So the literature tends to look at all of these things and go, these are toxins that, even some of these proteins might act like a prion, which is a very weird toxic little protein thing, kind of like a virus, but not a virus, that can infect a brain and cause havoc in a brain. So I just struggle with that conceptualization, and that's kind of why I'm doing this deal. Because it's just hard for me to believe that our designer, even with all of our different genetic variability and the possibility of mutations and epigenetics and all that kind of stuff, that our designer would have it such that some of our processes in our brain are actually making toxins to the brain itself. And this list is going to continue to grow the more we take snapshots of the brain. And so my argument is we need to look at this, stop looking at this from a toxicity standpoint, stop looking at it from an immune standpoint, stop looking at it from an inflammatory standpoint. Not that those aren't relevant, but make a shift in gears and looking at this in terms of a metabolic phenomenon and what is going on in the brain under threat. And in this case, you know, we're talking about traumatic brain injury and concussion and CTE, but let's not forget about all these other threats that may be playing a part in the brain's physiology and metabolic function. So when we look at TDP-43, this is very involved in RNA transcription. It's very involved in the metabolism of our brain cells. And so what happens under stress is this TDP-43 clumps up into stress granules, okay? And so it's not active, and we're not doing the normal, what we would call the normal functions of the cell when we're in a more normal state. But this may be very consistent with what it should be doing by design in a state of threat and stress. Because when you eliminate the stress, the granules open back up and the TDP-43 goes back to work, and you start getting RNA transcription and enzyme production and tissue production, and the cell you know, grows back, kind of thing. So I have a hard time saying that this is actually a toxic granular protein in the brain. It seems to be very much related to the metabolic functions of the brain cells. Now, if we look at tau protein, which is, you know, in all of the neurodegenerative disorders, perhaps more so in the ones that have axonal type processes going on, like CTE and ALS, and perhaps even with Parkinson's, the tau protein will, in this kind of physiology, will become hyperphosphorylated and then clump up into neurofibrillary tangles. And we've determined these neurofibrillary tangles as being toxic to the brain. Well, tau is very integrated into the formation of axons. It is responsible for making the microtubule of the axon. And so it's very possible that in a state of threat stress, when we're starting to downregulate certain parts of the brain strategically, that it goes relatively offline. And as these guys go into stress granules, perhaps this is the natural offline state, is to go into a little bundle, a little tangle, until perhaps they get a signal, you know, more anabolic signal that it's time, the threat is resolved, it's time to go back and repair, and we need to rebuild microtubules and axons. So tau protein, again, is very involved in a metabolic process in the neurons. And then similarly, this alpha-synuclein is kind of like perhaps the tau protein of the axon terminals, where it's helping to build these terminals where we store all of these neurotransmitters for release to do all kinds of stuff and communicate with other nerves. So this has also been characterized as a potential toxin in the brain, and maybe it's just a a dormant protein kind of sitting on the sidelines waiting for a signal to get going again. Beta amyloid is very interesting in the mix. So this is like, you know, the kind of the first thing we ever learned in Alzheimer's. This is a disease, an amyloid deposition disease, and it's primarily beta amyloid. Well, maybe so, but beta amyloid has a very distinct metabolic function as well. In the cell, it takes fats in the cell, and you have to remember that that all of these little organelles have fat in their membranes, and the cell body has fat in its membrane, and so what the beta amyloid tends to do in the cell is to be able to take fat within the cells and take it to the Golgi organ, where it can be actually packaged up and probably for exocytosis, meaning it's going to package some of the fat from the cell and then take it out to be taken out of the cell and perhaps delivered to other more prioritized areas of the brain, or perhaps even further to other more prioritized areas of the body. And the assumption would be in this case for fuel, not structure, but for fuel to be able to finish the fight and flight. So I think beta amyloid, you know, that it becomes very interesting under the metabolic lens. Now, we've talked in depth in past talks about ApoE4 being a lipoprotein that is responsible, as a lot of the lipoproteins are, that for transferring fats throughout the body. So my contention is ApoE4 is playing that role in neurodegenerative disorders to get fats from certain parts of the body to preferential parts of the body for metabolism. And we know that people with a double allele of ApoE4, meaning genetically they have two ApoE4 producing genetic type are at higher risk for neurodegenerative disorders. Well, I wonder if that means they have more of this toxic ApoE4. Probably not. Probably actually just means that they're hypermobilizers. So they're really good at mobilizing resources to move them about the body for the fight and flight. But unfortunately, with certain parts of the brain that have been deprioritized, have been down-regulated, perhaps even trying to go dormant for a while, it means pulling more resources away from that area. And you could see where there would be an evolutionary advantage to being a good mobilizer of resources. I mean, if you got to run from the tiger for days and days, and you can mobilize really well, that may be a great survival trait that you have, having these two ApoE4 alleles. So I'm just going to, question whether all these things are really toxic, or perhaps just part of normal physiologic processes after trauma, under threat and stress, and that these cells are in the process of down-regulating and trying to go dormant. And so you can see where these long branches, the axons and the dendrites, might start to deconstruct as the cell pulls in, so it only has to maintain its core functions, and how that could play a part in it. And I do agree, if this goes on too long and it's actually causing these cells to completely destruct, that becomes a big problem, because they are hard to reproduce, and it's even harder to reproduce their connections. But I think we still have to look at this. It may look like it's a toxicity to the brain, because the brain is shrinking in areas and cells are becoming dormant, and then cells are starting to sort of auto-destruct. But it may be more of a normal physiologic process than we realize, And if we keep chasing treatments that are trying to eliminate these things that aren't even toxins at all, we are gonna, I mean, we've got our gun pointed in the wrong direction. We're not even focused on what's gonna really help solve this problem. So I think that is probably all I want to say along those fronts. Let's go ahead and pivot over here and talk about why we don't heal properly. So the threat and stress could be repetitive head injury, okay, that we never get through a process of healing. And remember, when degeneration or catabolism, tissue breakdown, exceeds the rate of regeneration or anabolism or tissue building, we will see a degenerative process. So if we have recurrent head injury and we never completely recover from that, we can get into this chronic state of having excessive pro-inflammatory and catabolic cytokines circulating, and we get into this catabolic process in certain parts of our brain. So we have to consider repetitive head injury as a perpetuated threat-stress response. But we have to consider this in the treatment of brain injury. Where are people on the threat scale? How much of this stuff is going on? Probably one of the most well-known cases of CTE is Aaron Hernandez. Played tight end most notoriously for the New England Patriots, and he was very good. And he got into behavioral issues, he got into some significant social issues, and he eventually ended up killing somebody and then killing himself. And when they did his autopsy, he had profound CTE. Well, I won't go into the whole story of Aaron Hernandez, but he had somewhat of a tormented childhood. And so you start thinking about, was he at risk because of being a double allele ApoE4 guy, or a repetitive brain injury because he played tight end in the NFL, or was his biggest risk this stuff going on in the shadows of the brain? Threatening predictive codes that continue to run and keep our cytokine levels elevated, traumatic memories from his childhood popping up. And he's a football player. He's got to be tough, right? So who are the tough guys in the world? Military, NFL football players, sports heroes, medical people tend to repress a lot. So he may have had a huge weight going on here that affected his brain and essentially took him down this path of symptoms to the point of homicide and suicide, which is really tragic. But then other folks may, just have spiritual issues, emotional traumas in their life, emotional pain, social traumas and pain in their life, being victims of isolation, disenfranchisement, discrimination, injustice, things like that. Or people who are living in poverty may be more at risk for sustaining this threat level and these pro-inflammatory cytokines that cause this deregulation, I guess we can call it in the brain, but the degradation of the brain and the tendency of cells to want it to go into dormancy, if not eventually be destroyed. And then we have these other issues as well. The viruses, the bacteria, the parasites, the mycelium. Today we talked about prions briefly, kind of fall into that category. The lions, tigers, bears, other people, motor vehicles, guns, toxins, radiation, and I always throw in opioids are part of the threat stress system and can perpetuate this problem. So what do we want to do when somebody has a traumatic brain injury, including these relatively minor looking ones of concussions, so that they don't go to CTE? We need them to heal, okay? We need to cause healing of the initial injury, but to heal, we have to deal with the entire threat load. We can't leave any of this off. And I would also argue that, you know, we may be eventually here able to determine the level of healing with laboratory values, as well as our normal kind of psychometric and physical testing that we do to look for healing. I would argue that if somebody has a persistently elevated interleukin 6 level, but you could pick, you know, any of those cytokines, that we haven't healed them yet, and they're at risk if they go back to play, particularly if they get another brain injury, for going on to post-concussion syndrome, prolonged post-concussion syndrome, and to CTE. So when we look at these folks who have suffered a concussion, let alone multiple concussions, we need to get into some of our healing strategies here. And again, this is the same list, basically, more or less, that we used for, you know, COVID and back pain, and, you know, they're all mediated by this kind of same phenomenon. So we need a good diet. It needs to be plant heavy. It doesn't have to be all plant-based, but plant heavy certainly helps. People need to be fasting for 10 to 12 hours overnight so that they are getting enough ketone production, because we know that ketosis and ketones markedly drop pro-inflammatory cytokines and elevate anti-inflammatory cytokines. So diet and fasting and sleep become very important. Sleep, that's a good segue right into sleep. We need at least 8 hours. And we need adequate melatonin production, because melatonin not only drops the pro-inflammatory cytokines, all these listed here, but jacks up interleukin 10 and jacks up brain-derived neurotrophic factor and other growth factors in the brain. It's the anabolic piece of this that we need to get going. And we don't produce enough melatonin when we're looking at screens, playing video games, watching shows, even being on our phone, and living in this world with all this ambient light. So melatonin is very important to the healing response for a brain injury. Again, we'll cover these. Vitamin B, I love vitamin B3 in terms of its effect on pro-inflammatory cytokines. Vitamin C also drops pro-inflammatory cytokines. Vitamin D drops pro-inflammatory cytokines, and vitamin K2 also drops pro-inflammatory cytokines. The magnesium family also helps to drop pro-inflammatory cytokines. It has some nice other properties on vascular beds and perfusion of the brain, and needs to be part of a healing process. We can almost take as much magnesium as we can tolerate, but some of the concoctions give us diarrhea, so that's limiting. You can take Epsom salt baths and absorb magnesium through your skin, or you can use some of the versions that don't cause diarrhea. Zinc is very important for enzymatic function, both breaking down of pro-inflammatory cytokines, but also building of anti-inflammatory anabolic cytokines, and in general for many of the enzymatic functions that occur in the body. So we can't afford to be zinc deficient, but too much zinc can be toxic, so we just want to make sure we're getting enough, because under threat and stress we tend to burn zinc, so it may require some replacement. The cholinergic system is our anti-inflammatory system, and it's important that we have enough cholinergic activity in our body. So we'll go right here to our vagal stim strategies. So the vagus nerve is something that runs throughout our body, wanders and innervates our organ system, and throws out a lot of acetylcholine as its major transmitter. So that's kind of the bodily version of it. But this cholinergic system also exists in the brain. The cholinergic system, particularly this nucleus ambiguous, the ventral vagal system, not just giving input to the vagus nerve, we call it the ventral vagal system, but it's giving input to the entire brain, and essentially secreting acetylcholine out and acting as an anti-inflammatory system to the body, and the brain. So we need to activate that system. We can do that through many different vagal stim processes. Controlled breathing is actually one of those, but we also have vagal stimulators out there. Social interaction stimulates the system. So I won't go into excessive detail about vagal stimulation, but we need to activate this system because it is the counterbalance to the threat stress system. And there are some things that are helpful. Phosphatidylcholine produces acetylcholine when it's combined with acetyl-CoA, and acetylcholine is a major neurotransmitter for this healing system. So it's important that we're getting enough of these sort of good fats, good fatty acids in our body so that we can be producing you know, acetyl-CoA as well as other things. So we have a list of cholinergic type medications here that can be helpful in healing. I always point out that nicotine is a cholinergic, highly addicting, but it may have a role in healing neurodegenerative issues as well as some psychiatric diseases. We get down here to sort of if this is our anti-inflammation, anabolic healing system, the GABAergic system is very much part of our relaxation system. And so we can use certain medications to help heal. We don't want to cloud somebody's cognition too much in the process, as these can be a little bit sedating, and as attention concentration is problematic, you don't want to overuse these. But if people are also having headaches and muscle spasms and things like that associated with a concussion, it's very reasonable to put them on a GABAergic medication to relax them a little bit. They also drop pro-inflammatory cytokines. Prazosin is a medication that helps control anxiety and agitation, but also helps maintain perfusion to this part of the brain that's kind of being down-regulated. And so prazosin can be really good. It can be used only at night, where it can help get people so they can sleep and rebuild in sleep. Tizanidine also has some, you know, sedating properties, but it is neuroprotective. It decreases pro-inflammatory cytokines, helps with perfusion, blood flow to the brain, and it could also be used. I think tetracyclines, particularly minocycline, is particularly interesting in this mix. It seems to do really well in being neuroprotective and dramatically dropping pro-inflammatory cytokines. And then we get down into actually the possibility in somebody who's really having trouble recovering, and that's not to ignore any of this, you don't jump to this, but using cytokine blockers, so interleukin-6 inhibitor, tumor necrosing factor inhibitor, those are all possibilities. And then we kind of get down into this a little bit more questionable category, but there's been discussion about the tyrosine kinase inhibitors being used for neurodegenerative diseases. They block an enzyme that is involved in so many pathways in our body that are important to us, that I honestly don't think this is a very good idea. But because it's in the literature, I wanted to put it up there. The premise with using it is that with neurodegenerative disorders, there's kind of a hyped up immune response. And I think this is more of an inflammatory and metabolic response, and I'm not sure that using this is a good one. The interleukin-1 inhibitor, you know, may be really interesting in sort of the demyelinating process. I'm not sure so much specifically for concussion. And then interleukin-17 is always an interesting one because we have a good inhibitor out there, but I don't see a lot of information about interleukin-17 in neurodegenerative literature yet. Some of the more obscure ones are the phosphodiesterase inhibitors, the role of things like ketamine and psilocybin, the role of what previously has been considered an opioid inhibitor, naltrexone, but we know that it actually decreases some of the microglial activity and secretion of the pro-inflammatory cytokines. So it's super interesting. Don't have a lot of information on it. And head injury, though, H2 gas is kind of interesting. And then I just do want to mention down here this last line of supplements, glutathione and N-acetylcysteine, as well as alpha lipoic acid, particularly the glutathione. What's happening up here that we've talked about in the past is these pro-inflammatory cytokines, they change metabolism and they increase insulin resistance. And so what happens under concussion traumatic brain injury is when these come out, these cells up here, which are pretty much dependent on glucose metabolism, sugar metabolism, become insulin resistant, and they can't effectively use glucose for their metabolism. And so what they end up doing is, as the blood-brain barrier opens up and the fatty acids can get through it now, these cells that are particularly under attack in neurodegenerative disorders, concussion, CTE, they start metabolizing fatty acids. But the oxidization of these fatty acids creates a reactive, how do I want to say this, creates metabolites that are somewhat toxic to tissue. And so we have to be able to effectively downregulate the metabolites of the oxidization of fatty acids. And glutathione is super important in that process. So if it gets chewed up, and used up, then we can't downregulate, diffuse these metabolites that are increasing sort of inflammation and tissue destruction in this part of the brain. So I want to bring up glutathione and then also circulate all the way back up to this, because this now becomes even more important. If these cells have become insulin resistant, are unable to use glucose for their metabolism, and burning too many fatty acids causes some increased inflammation and tissue destruction in there from the metabolite of fatty acid oxidization. What we want to be doing in this case is shifting the metabolism to ketones and ketosis, because these cells can not only burn ketones for fuel to keep them healthy and going, but that helps to downregulate the toxic side effects of fatty acid oxidization, and it also downregulates the pro-inflammatory cytokines and increases the anti-inflammatory cytokines in that part of the brain. So that's actually pretty cool. So I think probably with that, we'll go ahead and wrap up. Just a quick summary again, though, is kind of the same points I make over and over again. Is, you know, we have these events, these physical events that we get super focused on, and we tend to, you know, get a very narrow window or a small lens by which we start looking at things. And I think that my argument here is that multiple brain injury moving on to CTE is probably less about local toxicity, less about immune responses and inflammatory responses. They're important. I'm not going to minimize that totally. They're important. But more importantly, they're about the physiologic choices our body is making under a threat stress state. And those choices tend to be much more geared towards the fight and flight, or even freeze and faint, and how we survive the attack. Okay, so we have to look at this also under this strategic physiologic transition and metabolic transition that's occurring, again, underneath polyvagal and cytokine theories. And then we have to look at total threat stress load, because simply eliminating the threat and stress doesn't necessarily seem to be adequate for complete healing. If we've got a whole bunch of this stuff going on, if this thing is really loaded up with threat and stress, we can get stuck in that degenerative, downregulated kind of state where these cells are going dormant and maybe eventually sort of auto-destructing. They're actually sacrificing themselves, cannibalizing themselves for the better of the total organism in the fight and flight. So in summary, CTE may be very much a biopsychosocial phenomenon, and we have to look at it underneath that lens. And finally, we need to have better measurements to determine when somebody has completely recovered. And to completely recover from a concussion and prevent CTE, they may have to also be recovering from all the traumas of their life, historical and all of their active traumas of their life, to actually heal, to actually regenerate. And there may be some markers we need to be looking at, such as interleukin-6 levels. Hopefully plasma interleukin-6 might give us the answer. Cerebral spinal fluid might give us a better answer, but it's kind of invasive to get. And maybe we can even find some neuroimaging over time that can clue us into how well somebody has healed. So there are a lot of things to be explored coming out of this, but hopefully we can move forward with allowing our military people to have better opportunities to heal, let alone our athletes and other people who suffer from these conditions. Thank you.